The following episode is brought to you by the American Urological Association.
Good afternoon. My name is Jay Rahman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series, with this specific podcast being one of several that really highlight either new guidelines or important guideline amendments. The title of this podcast is Treatment of Non-Metastatic Muscle-Invasive Bladder Cancer, and this is really highlighting the amendments from the AUA and SUO consortium that compiled this, and it's really my pleasure to host Dr. Jeff Holzbeierlein. Dr. Holzbeierlein is a vice president and physician-in-chief at the University of Kansas Cancer Center. He served for a number of years as chair of the Department of Urology, and I would say most salient, perhaps even for our discussion today, is that he was the chair of the guidelines panel and the amendment panel. So, Jeff, first of all, I know you have a very busy schedule. We and I are obviously deeply grateful of you taking some time to share with me and our listeners some of the new amendments and updates for muscle-invasive bladder cancer.
Thanks, Jay. Happy to be here. Excited to share some updates on non-metastatic muscle-invasive bladder cancer treatment. Rapidly evolving space, both for muscle-invasive and non-muscle invasive. So excited to share some of those with you all today.
So, Jeff, maybe just as we talk about this, and I guess I would preface a lot of this and say that, I think maybe our goal is to highlight maybe some of the nuances and the new changes with the amended guidelines, understanding that I think we will have references listed for our listeners to go and read the entire guideline in depth. But I think obviously when the amendments are done, there's a process to it. So without going into a lot of detail, just talk a little bit about ballpark, like amendments, how often do they occur roughly, and what's the process, just so our listeners understand that where did we come from, where are we now, and maybe when would we see more amendments in the future?
Great. Yeah, Jay, I'm glad you asked that question. I do think sometimes, particularly when we publish amendments to the guidelines, people aren't always clear why certain things get included in the guidelines and why things may not get included in the guidelines. So the guidelines for non-metastatic muscle-invasive bladder cancer were originally published in 2017 and then first amended in 2020. And then we amended those guidelines last year. It's important to remember that the AUA guidelines are evidence-based and that it does involve a systematic review that is performed by a methodology team up at Pacific and Northwest Evidence-Based Practice Center. For this particular guideline, they reviewed literature from May 2020, which was from the last guideline, to November of 2023. In order for the committee to consider a change in a recommendation, so if we're going to make a recommendation or a standard, it's important to remember that it has to be a published study. We cannot include abstracts, presentations, or even maybe sort of what we know as sort of a trial result. We're certainly able to include that when we say expert opinion or clinical principle, but as far as making an actual recommendation, unless it's been published, we're not able to include that in our study. So I'll point that out a couple of times throughout the discussion today, because people are going to say, well, gosh, well, what about this study? Why didn't you include that? And I'll try to explain why that was the case. And then finally, I just want to thank my committee members who also were involved in this amendment. That includes Sam Chang, Andrew James, James McKinnon, and Ann Schuckman. And in addition, we had significant staff support. I think as anybody who's participated on a guideline knows, it really does take a village, and we have our staff as well as our sort of data consultants, which included David Buckley, Rebecca Holmes, Brooke Bixler, and Aaron Kirkby. So with that, that's sort of a little bit of a background on the guidelines.
No, that's great. And I think you highlighted such an important point, which is, that a lot of these are made with the evidence that is in hand at that time. And obviously, we're going to talk about the shifting landscape and hence the genesis of some of these amendment statements. So maybe we'll start with the first. And you really sort of alluded to it when you said that bladder cancer, and we're speaking about muscle invasive, but even non-muscle invasive, it is such a rapidly shifting landscape, and particularly muscle invasive bladder cancer with sort of the integration of systemic therapies, along with, I think what most urologists, really think about, which is surgery for muscle invasive disease. So maybe talk a little bit about the specific guideline statements that are helping give us guidance on integrating systemic therapies, and what are those systemic therapies, and what are the scenarios that we should use them in?
Yeah, so I think that is probably one of the most rapidly evolving areas within muscle invasive bladder cancer is the addition of novel therapies, and in particular immunotherapy. Guideline number 9, which was talking about the use of adjuvant therapy after cystectomy, really didn't have much updates regarding chemotherapy, but it did have an update that is important to remember regarding immunotherapy. So the guideline reads that patients who have not received cisplatin-based neoadjuvant chemotherapy and have PT3 or PT4 or node-positive disease after cystectomy should receive adjuvant cisplatin chemotherapy or adjuvant immunotherapy. And in particular, the addition of immunotherapy is new. So that was primarily based on the Checkmate 274 trial, which was published in 2021. That trial examined the use of nivolumab immunotherapy administered to high-risk patients after cystectomy. It was a randomized trial. Patients could have received neoadjuvant chemotherapy and had YPT2 or through T4 disease and or node-positive disease, or if they did not receive neoadjuvant chemotherapy and had PT3 or PT4 and or node-positive disease, they were randomized to receive adjuvant nivolumab versus observation. The scheme for nivolumab was that it was administered every 2 weeks for 1 year. And in this study, it did demonstrate that patients who received adjuvant nivolumab in those groups had a significantly improved disease-free survival as compared to those who had observation. Hence, based on this, the guideline does recommend the addition of nivolumab, or in this case, immunotherapy, in these patient groups. It's important to remember, though, that studies have been somewhat conflicting. The atezolizumab study which was the InVigor study, examined the use of atezolizumab in these adjuvant groups, and essentially the exact same schema. And unfortunately, this trial did not demonstrate an improvement in disease-free survival, as well as reporting a much significantly higher rate of adverse events, particularly grade 3 and grade 4 adverse events that have been previously reported. So again, this really sort of confused the picture a little bit, but based on, again, the randomized trial of nivolumab, the committee did recommend its use. Importantly, too, since that guideline has come out, Ambassador has reported out. And so the Ambassador trial was the use of pembrolizumab in patients after radical cystectomy. It was a slight bit different because they used PD-L1 as one of their randomization characteristics, which had not been previously examined. And in addition, they are also reporting overall survival. So as opposed to the other two that reported disease-free survival, this one was looking at overall survival. The patients received pembrolizumab every 3 weeks for 1 year, again, for similar risk groups as previously mentioned. And in this study, it did demonstrate a statistically significant improvement in disease-free survival for adjuvant pembrolizumab. At the time of the publication of Ambassador, which was published in the New England Journal of Medicine, there was no difference in overall survival, but it should be mentioned that they had not met the number of events to report out yet. So will remain to be seen whether there's an overall survival. But again, based on disease-free survival, we'll wait and see what happens with overall survival. Finally, I do want to just mention that there was a recent study that was published, many people might be familiar with, a subgroup of the Ambassador trial that reported on the use of circulating tumor DNA, which I'm going to speak to a little bit later on. And it did show that in patients who had positive ctDNA tests after cystectomy, there was an advantage to adding atezolizumab in that group. So it may be that's an evolving story a little bit as well. Certainly atezolizumab has not been approved at this point in time. Nivolumab and pembrolizumab to be used adjuvantly at this time.
That's no great summary, and I think you hit sort of some of the real highlight trials that explore the use of immunotherapy in this space. Maybe I'll ask you a few questions on this, and more for your thoughts than anything else, good, bad, or otherwise. So, do you think that some of the differences that we are seeing between immunotherapy agents, is this a function of the agent, or is it a function of the patients being accrued in, and as you alluded to, maybe those that had staining versus not staining, versus maybe the inclusion criteria for that? Any broad thoughts that you just have on this?
I mean, I do think in general, people think it's probably patient selection in the groups. Those are obviously post hoc analyses and things that were not initially powered to detect differences. And so, you always have to be careful about sort of those types. But fundamentally, it doesn't seem to make sense to me that nivolumab would work and atezolizumab wouldn't work, although there are differences in the drugs, and certainly, even in kidney, we've seen different agents have different efficacy. So I think at this point in time, a little hard to say. What I would say is, if I'm going to refer a patient to medical oncology, I would expect that they're going to either get adjuvant nivolumab, or when pembrolizumab gets this indication, pembrolizumab, based on the trials.
Second question, just sort of in this space, and again, your own experience maybe at Kansas, for example. Obviously, you highlighted that in the neoadjuvant space, cisplatin-based chemotherapy is still the standard of care. Any differences in your practice pattern using different types of cisplatin-based regimens, whether that's gemcitabine cisplatin, GemCis versus MVAC? Is there a certain practice pattern that you've embraced at Kansas between even cisplatin-containing therapies?
In my own practice, no. I would say that it tends to be patients who maybe are not quite as fit with maybe a not quite as good performance status are going to get gemcitabine cisplatin, versus those who tend to be younger as well as maybe a little bit more fit are going to tend to get docetaxel MVAC. We did examine that, and unfortunately, there really isn't any published data showing a significant difference between the two. We reviewed that literature as well. There have been some signals that perhaps DDMVAC might be slightly better, but there's not been significant randomized evidence at this point to say that one regimen is superior to another. And so the committee did not recommend any particular type of neoadjuvant chemotherapy outside of noting that it must be cisplatin-based. We do know that carboplatin is inferior in this group in the neoadjuvant space. And so we do not recommend carboplatin. And in fact, if patients are cisplatin ineligible, currently the recommendation is to go straight to radical cystectomy.
And then maybe the last question in this space, and I'm sort of asking you to predict the future, but let's say we have this guidelines amendment in 2 or 3 years, probably 3 maybe ish. Your sense on, and I know there's more work being done on this, but neoadjuvant immunotherapy, maybe for those patients that are platinum ineligible. Was there any data on that at the time that you were doing the literature review, and your thoughts maybe on that being an area that may be part of the neoadjuvant scheme in the future?
Well, you're stealing all my future directions points here for later in the talk, Jay. But yeah, I mean, I can go ahead and cover that. I think, we have the highly anticipated report out of the Keynote trial using enfortumab and pembrolizumab. I think people expect that's probably going to be the new standard of care, which will be EB Pembro in the neoadjuvant space. But we expect that to report out, I think, late spring, early summer. I think some people think it may happen at Big ASCO this year. But my guess is that's probably either going to be the superior regimen or at least an alternative regimen. So we'll wait and see. But that, if I had to predict the future, that looks pretty promising.
Great. So maybe we'll pivot a little bit, and we've talked a little bit about integration of systemic therapies. Maybe we'll spend a little bit of time talking about 2 different elements of the surgery itself, of radical cystectomy, and then maybe thereafter lymph node dissection. So let's talk about radical cystectomy, and maybe talk to us a little bit about maybe the panel's review and guideline regarding sort of extent of local resection, men, women, different changes and rationale.
Yeah, I think this is probably one of the more optimistic, if you will, or maybe one of the more important things that we really should be changing our practice on, and that is the sparing of female pelvic organs. So this is Guideline Statement number 11, which states that when performing a cystectomy in males, the bladder, prostate, and seminal vesicles should be removed. So that represents no change. However, in females, clinicians should consider removal of adjacent reproductive organs based on individual disease characteristics and the need to obtain negative margins. Organ-sparing procedures in females should be considered based on disease location and characteristics on an individual basis. And that is a change for our recommendation regarding the extent of radical cystectomy in females. The committee considered published data regarding the involvement of gynecologic organs at the time of cystectomy. And although there really wasn't any real new data, as we reviewed sort of a lot of retrospective data and other data, it really became quite clear that the involvement of the reproductive organs is exceedingly rare. One retrospective review that was considered and included and referenced in the guidelines included 360 patients from 2012 that showed that the involvement of these organs occurred in less than 4% of patients. And in those patients, the most commonly involved site was the vagina. Other organs such as the uterus, ovaries, almost never are involved. Less than 1% of the time are those involved. And so based on this, as well as the significant improvements in quality of life and particularly sexual function in women who have their gynecologic organs spared, we felt that this should result in a change in our recommendation. Now, this is an expert opinion. This is not, high level 1 data, so it's important to remember that's what it is. But based on the committee's sort of review of the data, we did change this. In addition, just to mention, and again, not something necessarily, well published or talked about, but we did have a discussion. I think it's worth mentioning that there's a belief that now many of the ovarian cancers actually arise from the fallopian tube as opposed to the ovary. And so the standard removal of the ovaries is something that probably should be reexamined. And unless there's a strong reason to remove the ovaries, whether that's patient wishes or some other reason, we actually are recommending just removal of the fallopian tubes and not removal of the ovaries at the time. We do know that ovaries, even the postmenopausal female, can continue to emit small amounts of estrogen. And so we do feel like there's data to support continued preservation of the ovaries. But again, not a lot of published data in this area for cystectomy, so remains to be seen. I do want to just mention that, I said we didn't change the recommendations in men. That's because the involvement of the prostate or prostatic urethra was found to occur in up to about 27% of patients. And so it's not an uncommon thing and can sometimes be challenging to diagnose preoperatively in patients. So we felt that it still did warrant that. In addition, if you sort of look at the data of prostate sparing versus nerve sparing, outcomes are about the same in terms of sexual preservation. So we felt that a better oncologic surgical procedure was removal of the prostate with a nerve sparing in selected patients.
No, that's great. Really well summarized. Maybe maybe this is something. So I'm gonna plead ignorance right out of the gate. Maybe this is something you were going to cover a little bit later, but the decision making regarding the female organ preservation. Obviously, the guideline statement talks about disease location, characteristic on individual basis. Maybe talk to us a little bit. Is that physical exam? Is that imaging? If it is imaging, is this something that maybe has better soft tissue resolution, like MRI versus CT? Like just in practice, as one goes through trying to make that decision, what are the factors maybe for you or that you kind of think about in that space?
Yeah, so I do think, particularly in women, and if you go back to guideline statement number 1, we talk about the importance of exam under anesthesia. And again, this is a clinical principle. This is not something with there's rigorous data, but it's something that I don't think enough of us do. And that is when you take that patient for the TURBT, whether that's a rectal examination in male or female, and a pelvic examination, particularly in a female. And I would say, particularly for bulky tumors that are on the base of the bladder or maybe down towards the urethra, it's really critical. You definitely can pick up invasion of that anterior vaginal wall. And of course, I don't think that's a patient that's probably one of those properly selected patients for vaginal preservation. That probably is somebody who should have an anterior vaginectomy along with their surgical procedure. Now, with neoadjuvant chemotherapy, yes, it's oftentimes that may not be involved. And so again, I think that's where you have to use your clinical judgment. But, I do think that is something that can pick that up very well. I am going to speak a little bit about the role of MRI later on and VIRADs. And so that may help us be a little bit more accurate in terms of our assessment of local staging, and involvement of the anterior vaginal wall. But, really at this point would point to an exam under anesthesia.
Great. So we've spoken a little bit now about the cystectomy itself and some of the nuances, and you outlined really nicely some of the rationale of why radical cystectomy in men still includes removal of the prostate. A very nice discussion on why the thought process on the extent of surgery in women, when appropriate, doesn't maybe need to be quite as radical as it used to be. So now let's, I feel like the concept of lymph node dissections is always a bit of a Pandora's box, and I think something that in most medical meetings you'll have a myriad of debates on. Talk to us a little bit about the guideline statement regarding lymph node dissection for muscle invasive bladder cancer, and then obviously I think it goes back to one of the first points you made, which is data that's available at the time of the guideline crafting, and then data maybe that becomes available thereafter, and how that may impact perhaps future iterations.
Yeah, I think this was probably one of the more contentious things that we considered as a committee. I do think, as you mentioned, people have pretty sort of strong opinions about this. And certainly at many of our national meetings, we've had some pretty vigorous debates about this topic. However, given that, the committee did review the published literature regarding standard versus extended lymph node dissection. The current recommendation was for clinicians to complete a standard lymph node dissection. So standard lymph node dissection includes the external iliacs, the internal iliacs, and the obturator lymph nodes on both sides. And they do recommend a minimum of 12 lymph nodes that should be removed. So that lymph node number is primarily retrospective data. There's been some large retrospective series by a number of investigators. One recently was a SEER study that published that really showed that if you had a median of 12 to 14 lymph nodes, patients had better cancer-specific survival than those who did not undergo a pelvic lymphadenectomy. So, that's been the sort of recommendation for that standard number of lymph nodes. In regards to the extent of the lymph node dissection, in 2019, there was a prospective randomized trial conducted in Europe. It's subsequently been published. It included 401 patients. They received either that standard lymph node dissection that I previously described, or an extended lymph node dissection, which included the common iliac nodes, the presacral nodes, the pericaval nodes, and the interaortic and periaortic nodes up to the inferior mesenteric artery. So I think that is consistent with most people when they practice that extended lymph node dissection, may go all the way up to that inferior mesenteric artery. And so that's what was in this trial. The trial failed to demonstrate an improvement in recurrence-free survival in patients who underwent extended lymph node dissection compared to standard lymph node dissection. And at least in that trial, there was importantly no difference in the number of complications. But based on this trial, a randomized trial, the committee did feel that we would just recommend at a minimum a standard lymph node dissection, and that there was not data to support doing extended lymph node dissection. So you kind of might hear me hedging a bit, saying we didn't say you should only do a standard lymph node dissection and you shouldn't do an extended lymph node dissection, which leads to the discussion about SWOG 1011. And so everybody's going to say, well, what about SWOG 1011? Why didn't you include that? That one has shown some, an increase in complications. Why didn't you have come out more strongly? Remember, that's only been recently published. So we were unable to include that study. We all kind of knew most about that, but we were unable to discuss it. But just briefly, SWOG 1011 was published in the New England Journal of Medicine recently. In this trial, 658 patients were randomized to standard lymph node dissection or extended lymph node dissection. And similar to the European trial, it failed to demonstrate an improvement in disease-free or, importantly, in overall survival in patients undergoing extended lymph node dissection. The one difference, as I sort of alluded to a minute ago, was that in that study, there was a statistically significant increase in complications as well as postoperative mortality in patients who underwent an extended lymph node dissection. So we were not able to include this. We will be obviously at our next amendment, including that review, and we'll have to make a decision whether or not, come out a little bit more strongly in terms of a standard lymph node dissection. But we sort of leave it up to the practitioner to make that decision, but recommend at least, at a minimum, a standard lymph node dissection.
Great. No, it's a really nice summary of, as you mentioned, probably a topic where it's hard to achieve a consensus or at least a uniformity in that. And I don't think that's unique for bladder cancer, to be honest. I think you can pick a disease state and you'll get debates in many of them regarding extended lymph node dissection. So maybe in the last 5-6 minutes.
Jay, I just want to add on to that. I appreciate the ongoing debate. I think you have to decide whether you're going to believe randomized trials or not. But you have to also look to the other disease sites. And in none of those has an extended lymph node dissection been shown to be beneficial, whether that was gastric, whether it was colon, whether it was uterine. None of those have demonstrated an improvement in recurrence or overall survival. So I'm not sure that it's maybe as debatable as people think it is, just because, again, similar to many other disease sites where there was felt to be an advantage, and in fact, that's not been borne out. So just add that for a little more food for thought.
Yeah, no, very, very well said. Very, very well said. So maybe in the last 5-6 minutes, we'll do a little bit of rapid fire. I'll kind of pick your brain and a few of the future directions. Let's start with imaging. You mentioned briefly VIRADS. What is VIRADS, and where is that going to fit in the scene of muscle-invasive bladder cancer? Talk to us about that a little bit.
Yeah, so VIRAD stands for Vesicle Imaging Reporting and Data Systems. I think people are very familiar with PIRAD. So, it's a similar sort of scoring and staging system. This is used in bladder, and it's been used in both non-muscle as well as muscle-invasive bladder cancer. We know that, traditional computed tomography imaging is notoriously inaccurate for staging. I think VIRADS actually might have its most interesting use in predicting just muscle invasion, so maybe in the non-muscle to muscle invasive space. But there's also data suggesting that it more accurately stages patients when they have muscle invasive disease. So, leaning us towards T3 disease, we know that can be problematic to detect. And so, there haven't been any randomized trials, but there is mounting data, most of it retrospective, suggesting that it's quite sensitive, up to 89% sensitive for detecting muscle invasion, and quite specific as well. So I do think that we'll see some additional data coming out on VIRADS, and it may be enough for us to sort of incorporate it into the guidelines in terms of our imaging.
Great. Second sort of topic, we've spoken a lot about muscle-invasive bladder cancer, specifically talking about radical cystectomy. That's what we spend a lot of the time in the last two sections talking about. But I think we have to acknowledge that for certain patients, bladder preservation may be a very reasonable option, and probably should at least be part of the discussion for at least a certain percentage of patients with muscle-invasive disease. Talk about chemoradiation, but really maybe dovetailing with that, the integration of immunotherapy into that algorithm there, and how does that all fit in?
Yeah, I mean, I think, we've received, fairly or not fairly, a bit of criticism about our sort of stance on chemoradiation. There are obviously several studies that have been published that point to quite good outcomes with chemoradiation. The troubling thing about most of those studies is that they're highly selected patients. And so while the committee certainly recognizes that in highly selected patients that it can be a reasonable option, as we're speaking towards more of a general approach towards bladder cancer, I don't think the data has borne out to be as effective as neoadjuvant chemotherapy followed by radical cystectomy. So hence, our recommendation has been in patients who are either unwilling or unfit to undergo cystectomy, but desire curative intent. we do recommend chemoradiation. What is exciting is I do think that we're seeing some, and there's a large number of trials currently in progress looking at the addition of immunotherapy with chemotherapy and radiation for muscle-invasive bladder cancer. The U.S. trial has accrued, and we will be waiting that. That was using atezolizumab, so we'll wait and see what the results of some of those are and whether that's something that we would either change our approach in chemoradiation, or perhaps maybe the data looks good enough to say it's an alternative approach, but not enough data at this point in time. We'll have to wait for the next guideline for that.
Great. You mentioned a little earlier ctDNA, and obviously historically, our markers of disease for bladder cancer has really been imaging, axial imaging, CT you mentioned, MRI, but talk a little bit about what is ctDNA and how can we use that as part of our future tools to assess maybe residual disease, maybe guide use of systemic therapies, maybe refine that.
Yeah, I mean, I think this is one of the most exciting areas. I'm really excited about this. So ctDNA stands for circulating tumor DNA. It's the ability to pick up DNA that represents cancer cells, and it, I think, has the potential to guide us in terms of who should receive adjuvant therapy, whether that's adjuvant chemotherapy, whether that's adjuvant immunotherapy. I mentioned the previous report out in New England Journal of Medicine of the atezolizumab study. They were collecting ctDNA on that, and they went back post hoc and analyzed those patients. And those patients who received who had a positive ctDNA after cystectomy and received atezolizumab did have an improved disease-free survival. Mm-hmm. Remember, that was the IMvigor study that I mentioned that was negative. But when they subsequently looked at that subgroup, they did find that there was an advantage to that. I think one of the most troubling areas in bladder cancer has been our surveillance strategy. We just have terrible data in that area. We really have no data to support the use of CTs, how often we do CTs, PET scans, a variety of different things. And so I'm really excited that perhaps ctDNA, as we get more robust data, whether that's predicting recurrence or whether that's predicting, response to treatment such as adjuvant immunotherapy. I think that's going to be a really exciting area, and I hope we'll see enough data to include that in our next guideline.
That's great. Yeah, great summary of that. Jeff, any last thoughts that you want our listeners to have just in this space, or is there anything in particular that you think is just important that they walk away from and remember?
Yeah, I mean, I think, some of the things that, we know overall is that cystectomy is well underutilized. So, even though we have all these guidelines, some data would suggest less than 40% of patients with muscle-invasive disease receive any of these types of therapies, and maybe as low as 30% get cystectomy. So, we realize that it's a big surgical procedure with lots of complications. But, we hope these guidelines are intended to help guide clinicians when they're making those decisions. And, if they're not comfortable with that, then referral to a center where they're, high volume cystectomy center, I think is the right thing, since right now the evidence supports the use of cystectomy in muscle invasive disease.
That's great. Well, Jeff, really big thanks. I think we covered a lot of ground. You had a great summary, I think, not only of the new statements, but more importantly, I think sort of the rationale and some of the data which drove these. So, on behalf of our audience and the AUA, really appreciative of you taking some time in what I know is a very busy day to spend about 30 to 40 minutes with us. For our listeners, to go into deeper detail on anything that Dr. Holzbeierlein covered, please feel free to log on to AUA University, and tagged onto the podcast will be some of the sentinel references that he discussed so that you can feel free to read in greater detail. And we very much appreciate you joining, and hope to see many of you at the AUA meeting in a few months. Jeff, always good seeing you. You take care.
Great. Yeah, good to see you too.